I see a bunch of folks are joining. We'll give another minute and then we'll get started. All right, we're at 11:02, so I think we'll get started. Looks like we have a good quorum here. So welcome back, everyone, and happy October. Look forward to our 2 meetings this month. The commissioner will not be joining us today, but she will be planning on joining the October 26th in-person meeting, in-person and hybrid for those who aren't able to attend. And that is, planning logistics are getting finalized. We're planning on hosting it at the DSS office as of now, and we'll be sending out more information as time gets closer with exact logistics. So looking forward to seeing many of you who are able to make it. And I know a few folks won't be able to, and we'll definitely sad not to have everyone together, but look forward to the conversation. There are a few outstanding data items that we're still working on pulling together. We anticipate being able to send out some updates in the coming week or so. So look forward to an email with some additional data that has been requested. As you can see for our today's agenda, we'll be talking about first goals for today, and then really kind of delving into the next phase of work that we see this moving into for the committee and DSS. And so we're looking forward to the discussion on process and timeline, checking on that, and then also discussing delivery system and payment reform examples at a high level, and figuring how we're going to move forward. So if you go to the next slide, which just will go over the exact goals. So one is checking on the overall timeline and process for the primary care program design, review what's been accomplished already to date, and figure out where we're heading. And then 2 is review and discuss a range of primary care delivery system and payment reform strategies that have been implemented by other state programs to help inform upcoming discussions. Next slide. So this is the timeline for both where we have been and where we're anticipating trying to go. So this is our proposal. You'll see phase 1 should look relatively familiar. That was April through this past month, where we established the advisory committee as well as the subcommittee, discussed prior work that had been done, responded to requests for info, and did listening sessions. Discuss even more details on the next slide. But before we get there, we're envisioning moving on to a second phase of the work where we really start delving into more programmatic design features. And really starting this month, where we start to discuss some of those key design elements. So we'll look for some feedback from all of you today. And also talking about programmatic structure. And so those key things might include care delivery, performance, payment, and an equity strategy. And then that's the initial program design. And then would anticipate a second or third phase or second design phase that's more the technical design and implementation, March through December 2024 plus, essentially. So reviewing those key decision points, making technical decisions and getting feedback, discussing budget, authority, et cetera. And so that's the timeline that we're marching out. And we'll turn to get some feedback here in a minute from all of you. Next slide. And so this is just a reminder about activities and accomplishments, things that we've done to date so far. So laying the groundwork for more in-depth discussion to come. And so I already reviewed a few of these things, but we've discussed goals and aligned on an overarching goal of improving the biopsychosocial health and well-being of Husky members, especially for those most historically disadvantaged, in a way that reduces inequities and racial disparities. Acknowledge that primary care is one part of a comprehensive system of care oriented towards improving the health and well-being, acknowledging there's other efforts underway and those that are being explored to also address social determinants of health and health-related social needs. So primary care is important, but it's not the only component here. We had a listening session with all of you where we listened and got feedback about ways to better both the needs of communities and individuals to address health-related social needs and social determinants of health, and those broader strategies about how we might go about doing it. We reviewed some data, quantitative, qualitative, about access, quality, utilization, cost, experience, and equity. We did receive supplementary data requests, and we provided some, and we'll have some additional data that will be coming out. And we did review some examples of federal and state primary care models and programs in response to some of the questions that were answered, understanding that was not a comprehensive review and there will be further review needed. Next slide. So this is kind of the design components that think about as we move forward. So really having a cross-cutting equity strategy, goal of reducing inequities and racial disparities, and then talking about care delivery, performance measurement, and payment model. We'll talk a little bit more about these. So I think we can go to the next slide and talk about what the design components include. And so we're going to ask you for some feedback on this. And because obviously this is a key component of the program design details, are what's part of the care delivery, performance, and payment model. So under care delivery, think about identifying and addressing health-related social needs, integration with specialty behavioral health and oral health care, care team and care coordination enhancements, care transformation infrastructure, practice recognition and technical assistance, under performance measurement, thinking about quality measurement, data sharing, monitoring strategy, depending on what the model looks like, especially for things like underservice, thinking about the payment model, including base payment, care delivery, redesigned payment, and performance-based payment. So, Ellen, I see your hand. We're going to we want to have a conversation about this. And so we'll get to you just a second, if that's okay. And we'll come back to this slide to review and discuss. Just quickly on the next one, I think, Olivia, this is just a very high level kind of iterative and flexible schedule that we're proposing related to these conversations. We know this will need to get updated over time. We're obviously on the October 5th. This is a process check-in and review of program examples. We're having our in-person meeting. We're thinking to discuss care delivery redesign, talking about payment models, performance measurement, equity strategy review, program structure review. Again, high level, this would be phase 2. Phase 3 is, again, more technical design features. These would be the high level discussion, decision making. So we're going to get into discussion. Ellen, I know you have your hand up, so maybe flip to the next slide and then Ellen, jump in.
Actually, can we go back to, I think it was slide 10. And actually even further there, that one's good. Actually, 7 is good. I am concerned about the framing already of the payment model discussion, that we're talking about a base payment, a care delivery redesign payment. Actually, I'm good with that part. And performance-based payment. That implies capitation. And I just wanted to see if I'm reading that right. And then on slide 10, I have another comment.
Oh, and I'll jump in here. Yeah, hey, it's Guy. I don't think you are reading that right, but let me clarify. Base pay, so one could imagine, and by the way, I'm not breaking news or saying this is what I think we should do. I'm just giving it as an example. One could imagine a base payment to primary care providers to help them build out infrastructure, or a base payment which is contingent on quality measures, neither of which has financial risk or capitation included in it. So I think that base payment, this slide is meant to be purposely not controversial. I think we'll have a lot of discussion when we get into each bullet point, but we were trying to have a framework for at least outlining the set of potential options. And needless to say, if folks think something is missing, or should be added to the slide, love to hear it. But this was the like slide 15, maybe the place where we have lots of robust discussion, but this is meant to be flexible for the full range of things we might potentially do, including, but not necessarily having a base payment for the reasons I described, as well as having a base payment which does have financial risk.
Okay. Okay. I like your answer. I think that it would be better if the payment model didn't, at least in my mind, and it has for others as well, looked like, a dog whistle for capitation. And that's, a non-starter with a lot of our advocates. And I think it's something that we'll get into, I guess. And then
just to clarify, I do think financial risk is an option that I want to discuss. So I don't want you to read my answer as saying, I'm not saying that. What I'm saying is on this slide, we're not presupposing that on this slide.
Right. I got that.
Great. Okay. Sorry. I just wanted to make that clear.
Yeah. The other piece was on slide 10 around the literature around delivery and payment reform models is not conclusive. I think that's a massive understatement regarding the impact of these initiatives, and more research is needed. States have seen successes. Yes, they have. They have also seen a lot of failures, and many models have evolved over time. That is absolutely true. States have doubled down and thrown more money in, and so have the feds. I think, and I do need to get my lit review out, and Brad's gonna poke me on that, and he should. But I do have a day job, by the way. I think the literature is, I think that's a very, I would say that's a very biased statement, to be honest, a reading of the literature. I think the other issue that I'm really proud of Connecticut, actually, I have gone to, for years, I've gone to, national groups and everywhere I go talking about how well we're doing in our Medicaid program. And we bucked the trend and got rid of managed care organizations. And we are reaping the benefits of that, both taxpayers and members. But if you just looked at other states, and new people coming in who work in insurers can't believe we don't have managed care. Everybody has managed care. What's up with that? And we're doing much better. So I think always looking at other states is a mistake, and we're not Kool-Aid drinkers here. I think it's also really important to say, why don't we let other states waste their money and make mistakes before we jump in? We don't want to get behind other states. I've heard that said, and that concerns me a great deal. I think the other piece we need to look at, and may not be true for other states. I've talked to other states about MCOs. They were like, it really couldn't get any worse than it is really right now, Ellen. So yeah, we're willing to try MCOs. Well, it could get worse here. We're actually doing very well, especially compared to other states, and jeopardizing that just because other states are doing it is a bad idea, especially based on biased information. I'm done with my sermon.
Thanks, Ellen. And I'll just look forward to getting your thoughts on the literature. I just do want to underscore what's on the slide, which I think at least the first clause, I think is very fair. We say it's not conclusive regarding the impact of incentives, but definitely looking forward to getting that review out. Sorry, Brad, I didn't mean to take over. This is your meeting to run. I just wanted to respond to that research point. So.
Yeah, no, I think it's fair. And also just to say, this is directly from, this is from Kaiser Family Foundation report directly. And I think it's generally relatively measured, understanding, you can interpret that differently. So I think not conclusive is relatively true, though, even Ellen, as you're saying, our state has maybe seen successes with what we've done. I'd say there's other states that as well, but I think probably get back to, if that's okay, maybe slide 9, and we can come back to this as well. If otherwise folks want to comment on this, that's fine. But I think CJ and then Tiffany have their hand up.
Hi, good morning. This is CJ here. I have a very confrontational thing to say. Hear me out. So a couple days ago, I went for my medication and found out that Rite Aid closed down completely. Okay, I had to hunt my stuff down. What Ellen said there is very, very true. Okay, but I want to add to that, to what she said. I want to know, what are we really doing here? Okay, I did not receive these slide notes until 2 days ago. That's not enough time for a working person like myself. to read through this and have actual feedback. Okay. So I have a lot of issues here. And I think that what she put forward, we're doing well without the MCOs. This looks like you want to go back to a system that failed us completely. Okay. We have working people. I thought we spoke about diversity, access. I thought that's the point of this. How come we're not thinking about bringing us to the table before we create these lovely, beautiful slides so people could actually give their feedback? Thank you.
I'll just say, CJ, sorry, I didn't get them in time. We were definitely working on them until actually pretty recently. And so it took us a little while to get what we thought would be helpful.
That's fantastic. But let me tell you something. You are the state of Connecticut, and you came to us and you said you wanted the community involved. And we said to you that we want to be involved, but you keep putting the same people at different tables. So we do not get involved. So what's really going on here? And before you invite the Black and brown people and make them feel included, so you could then tokenize us and have us push your agenda, let's try, not to create a problem. This is not the first meeting where we received these slide notes a couple days before. This is unacceptable. But again, that's a separate issue. Going back to what Ellen just said, this looks like you all really want to push capitation. So what are we really doing all of this for? That's my question.
Yeah, I think I'll just say, I think definitely, and Guy, we can jump in at least on the MCO front. I don't think we have any interest in revisiting that as part of this conversation. This is really purely a payment for primary care and programmatic redesign component. And so I think capitation is something that, as we're talking about a base payments could be fee for service. They can look like anything. It's just what's the main way that providers are being paid, and that's really the only. Again, I think Guy's point of what he said, that slide's not meant to be controversial because any model could really fit within that in terms of how dollars are flowing to providers. Again, but really managed care is not something that I think is completely off the table as part of this conversation. Guy, let me pass it to you quickly.
Agreed. Yeah, they're agreed with what you said. Not going back to managed care.
Yeah, definitely not.
I'm sorry. I didn't hear that part because I'm outside. You said managed care is not off the table?
It is definitely off the table. It's not part of this conversation. We are not interested in pursuing any type of managed care approach at this point.
All right. Thank you for that clarification.
No worries. Yeah, and sorry, and I'll just say, we definitely want to make sure you have time to review these and look at them. We just, we'll try to get them out as soon as we can. Apologies for not having it soon enough. Tiffany?
So thank you all. I appreciate this conversation. We often talk about how well we are doing as a state, and I greatly appreciate it, but I would ask that we define what well is. So we may be saving money as a state, and that's exceptional. I am curious as to our outcomes for people of color in our state and how that is comparable. So I think we also need to align, and I appreciate CJ's perspective on the patient perspective as well. How are we defining doing well? And we just need to make sure we have some agreement around that.
Thanks, Tiffany. Yeah, I think that's a good point. I know we reviewed some data in August where, there's some indicators that the state has been successful in certain areas, but it also there's marked room for improvement across the board. And I think, if we're just comparing ourselves to other Medicaid programs versus to other populations, I think these are all questions that are important to think about, as well as thinking about what our key performance measures are over time for these programs. And I'll just say, at least for the maternity bundle work, thought about how do we define success, including thinking about success, meaning we're actually decreasing gaps for historically marginalized communities over time. And I think there's opportunities as we think about payment reform and also measurement to how do we set those expectations. Mark?
Thank you, Dr. Richards. If you don't mind, I'd like to share some observations from some conversations we had with the Hospital Advisory Council reps on this committee, but also other members. We had a chance to look carefully at all the data that you shared over the summer, which was much appreciated. We also augmented the analyses that you shared with close examination of the drivers for hospital encounters, whether ED visits or inpatient visits. We don't have access to the whole Medicaid data set the way you do, but we could look particularly at the folks who end up coming to the hospital. And some of the things that really stood out for us, well, foremost from your data, and keeping in mind the overarching goal of improving the biopsychosocial health and well-being of the Medicaid population. We were struck by the chronic disease prevalence statistics, and especially the rates of behavioral health disorders, asthma, diabetes, and hypertension in the Medicaid population. And that one could argue that if you want to have the broadest impact on Medicaid, to the extent that one can focus on the management of those conditions or the prevention of those conditions, that potentially provides a focus for the reforms. The other things that we noted was that when you look at hospital encounters, that those same conditions, asthma, diabetes, and hypertension, behavioral health, are among the top 10 principal reasons for visiting an ED, for going to inpatient. And all circulatory disorders, that is things like stroke and myocardial infarction, which are consequences of poorly controlled hypertension, are also well represented in hospital data. Substance use and psychiatric conditions are the second and third most common reason for hospital encounters as medical, disorders or conditions. The most common reason for admission is accidents or injuries, but it's, when you get to chronic illness, it's behavioral health. We also looked at ARC PQIs, preventable quality indicators, and we found that diabetes and asthma have the highest rates of preventable admissions of the chronic conditions that we looked at, and that there are extraordinarily high comorbidity rates. That is, that obesity, substance use, and depression are among the top comorbidities. And in diabetic patients, it's almost 50% have depression or anxiety or a substance use disorder. So, and finally, although overweight and obesity was not a primary focus of the analysis, it's not among the most common reasons people go to an ED or are admitted inpatient. It was recognized by our members that it's among the drivers of diabetes and hypertension and cardiovascular risk. So one of the things that we would propose is that as a preface or prefatory to discussing the primary care capabilities that should be the focus of the reform, is that we decide what it is we're trying to drive in the way of impact, and to use that as the basis for examining the capabilities most likely to enable that impact. And so our thinking is that the prevention and management of asthma, diabetes, hypertension, overweight, obesity should be central in pediatric populations. One might focus more on asthma, behavioral health, and overweight, obesity. And that, of course, acute and chronic behavioral health conditions, which are cared in a much broader system than primary care, nonetheless need to be a focus, behavioral health integration, because it is a factor in your success in controlling these chronic illnesses. And the sort of two other points, and then I'll stop. There was supporting the focus on these chronic conditions. It was noted that these are also conditions where there are marked race ethnic disparities in terms of admission rates and morbidity and mortality, and that there's already evidence that there's an opportunity for improvement, with poor control of diabetes being at about 36% and good control of hypertension being about 64%. And so there's plenty of room to try to narrow that gap and to make a difference in people's long-term outcomes and near-term outcomes. Finally, especially given the behavioral health issues and what it takes to succeed in chronic illness management, as we've discussed before, and I think you've acknowledged, there ought to be an eye towards systemic approaches and investments outside of primary care to augment our ability to make an impact. Final comment is that we strongly endorse the signal you've given that health-related social needs coverage should be should be considered as an element to the reform, and we think that putting into place coverage for HRSN and improving capacity to HRSN services would help a great deal in the success in primary care of managing those conditions. And I think it's where CMMI and CMS are headed with their latest models, and so we basically support what you've been focused on.
Thanks, Mark. Ellen?
I just would like to respond first to what Tiffany said, and I don't disagree. I've given a great deal of my time and energy over the last 30 years to inequities in the system, and those do still exist. The improvements, however, in the program over time, and it's not just when we got rid of the MCOs, it has improved over time, is not limited just to the money. It is about more kids getting more access, more providers, including primary care providers, are participating in the program. We have on many levels, maybe just a mountain of evidence to show that we have improved this program tremendously. Now, are there still inequities? Of course there are. And those please don't ever take what I say to suggest that we don't need to work on things. That is also something I've spent 30 years working on, sometimes knocking my head against walls with DSS, but I think I'm pretty proud of what we've done. And I think that my only point was we have to be careful not to do something, even though it sounds like a good idea, lots of things don't work. So we have to test things, we have to be sure that they're right, and we have to follow the evidence. On Mark, I would love to see that data. That would be awesome. That would be fun to see. And I'd really like it before I put out mine about, why we're doing well. I think it is, and I appreciate you getting us that, or discussing that, or at least sharing what you found. But I think it's important to recognize that you're looking at admissions and people who come into the ED. Now, those numbers have been going down significantly over the years. Now, they've been going down for everybody, but they're going down for people in Medicaid as well. So it's important to remember that you're looking at that population of people who had the accidents, who had the illness. I don't disagree about the need to look upstream. I guess I just maybe want to take a bigger picture than assuming it all and putting all the responsibility on primary care. It's just not going to work. These are public health issues. These are issues of, that are tied to the economy. They're tied to lack of housing. They're tied to an awful lot of things that are happening. And a primary care provider is not going to be able to solve all these things. Even a health system can't solve all these things. It has to be a much bigger collective. So I think drilling down and expecting too much from the primary care reforms and it is not going to work by itself. And I think we have to really consider that we have a lot to lose here too. I will stop now on my second.
Thanks, Ellen. And CJ, I see your hands up. I'm just going to go to you.
Yes, hi. Thank you. I'm also asthmatic. I want to add to what Ellen just said here, because the primary care providers cannot carry this on their own. The fact of the matter is, we have problems in the state, in the country, that are bigger than primary care. And hence the reason, as Tiffany pointed out, we need to really figure out what are the expectations here. I'm not hearing any of that. What I'm seeing and hearing is a very scripted presentation where, this is what happens, right? And who just got offended? Well, I'm offended by the fact that people mess with our healthcare. I haven't been with my required medication for almost 3 days now because somebody decided it was a good idea to go interfere with insurance and make it a multi-million dollar industry. Innocent people are suffering at the end of the day. So while y'all make excuses, people are sick, people are not using the services that are there because they're discouraged and they're not engaged. And for those who like to look at other things and say, let's just go do what over there's doing, that looks like something to do. People made a gamble on Trump, and here we are. Thank you.
Thanks, CJ. And just say, very sorry to hear about the frustration. I think lots of frustrations with our existing healthcare system. I think this effort likely will not be something that solves all of them. And I think just recognizing that this is a piece of a much larger puzzle that we've talked a bit about trying to address. We'll just say, like, this isn't meant to be a scripted. We're putting together a presentation to have a conversation, which is, I think, what we're having now, and hearing all of your feedback as we're trying to move this forward. And so that's kind of how we're trying to address these conversations, is to put together generally some information, try to bring up questions, and then engage all of you in a discussion where you provide feedback and thoughts on those questions. And so it's not meant to be us just talking at you, and it's meant to be a kind of curated discussion. And so do welcome feedback. And again, sorry we didn't get these ahead of time. Eve, do you want to add anything else?
No, makes sense. Yeah, I agree. Great.
I
I think just I think one indication, appreciate the perspective, feeling like it's scripted. From my perspective, I've spoke less than many people here, and I think that's very appropriate given the listening session. I want to keep that up, so I'm here to listen.
Anything, Angela?
Yes, good morning. I left the question in the chat because I would really like to get comprehensive feedback on what type of utilization measures will be used to show use across service disciplines. I get it that this focus is primary care, but a measure of the quality of primary care is a comprehensive look at what types of referrals are made so folks get holistic care. So primary care, mental health, dental, specialties, so that the whole body, mind and spirit is dealt with. So if you all could share, and also really interested in as to whether the data will be provided incorporating race, ethnicity, and language preference data, REL data. If you all can just give us some sense of expectation.
Andrew, just on that last one, that's not data that we have available. We did look to see if there's anything we have in terms of preferences on REL data. I do think one thing that the first thing you were kind of saying about what the expectations or what those measurements would be, we would actually be interested to hear your perspectives on what would be feasible. And I anticipate that would come up as part of this conversation, is to hear from all of you as we're thinking about what those measures should be as part of this process, and including at the individual provider level, as well as at the larger system level, about what are the components that we need to measure on an ongoing basis.
And Brad, let me just chime in with one. Oh, sorry, Angela.
And I do have a follow-up. So if you are not, SBC 1 was passed 2 sessions ago. Racism is a public health crisis in my mind. And so if you're not going to provide race and ethnicity data, could you at least show it where the data is geo mapped, right? So that we can at least extrapolate who we might be talking about. Because just looking at the state as a whole doesn't work for getting at the root of systemic issues.
Yeah, Angela, it's Guy. Great point. Let me just go back to the first question that you had on REL data, which is so important. And I just want to elaborate on Brad's response. We do have REL data for some of our members. Unfortunately, we don't have it on enough of our members. And that makes it a challenge to do the cuts of the data that you describe and I think really rightly point out are important. In general, there are a couple things that we can do. You've hit on one of them, which is looking at geography, and due to patterns of segregation, that is a good proxy. Two other strategies I'll just highlight. One is some states, and this is something that could be part of this reform effort if we wanted to. Some people might be more comfortable talking or giving their race, ethnicity, language status to their primary care doctor than the government, the Medicaid agency. And so, one could imagine having a pay for reporting of that data from primary care practices back to the state that would facilitate that analytics. Another approach is to look at quality measures that we know from other data sets have larger disparities, kind of disparity sensitive quality measures is a term, and to make sure that those are included in the program as a whole. So just to underscore what Brad was saying, and I do want to come back to your last point, but just the quality measures and the utilization measures, that's exactly the type of detail that we have in mind under the performance measurement, under the quality measurement. And those are exactly the type of thing that we want to get this group's input on. So it's not like we have a list today that we want to share with you because we want to listen to think about what makes sense. On the third point that you made on the data, and I know over the summer we spent a lot of time providing data and then listening carefully to what you all thought and sharing data back. On the cutting it by geography, that makes sense. Let us take that back to think about the timeline and feasibility, but I totally get where you're coming from, and I think that sounds like a reasonable ask.
And I'll just note that one additional thing that you might be familiar with, Angela, is there is a state level team and also DSS team working on improving that data. So that is ongoing work that is happening. And I hope, and I am very hopeful that it will improve kind of some of that, what we have access to in the future and make it even more meaningful. I think you had specifically asked about preferences potentially for race ethnicity, which is just not data that I think we have captured. But note that there is some data on concordance of race and ethnicity for providers and patients and outcomes, especially around things like colon cancer screening. I think Robin, your hand's up.
Yes, thank you. Thank you so much, everyone, in terms of the questions and also the conversation that has been lifted. I think one of the things that I think that I heard that was a little bit somewhat concerning to me, even as it relates to why we're here in terms of primary care. If we look at primary care, I don't know how we could not have primary care be a part of us really addressing the disparities that actually exist, as it relates to people of color, and that we all have to be in that, a part of that. And then as I think about also, just not using race, ethnic, and language data, even as we look at data that's actually being given and that's also being stated on today, especially around emergency room visits and some of those other things, it just makes me wonder that we also look at that through the lens of, REL, race, ethnic, and language data, because I think that other than that, we're kind of sitting here, but we're not really getting good data that would continue to speak to the needs and what it actually needs to happen, especially in the primary care arena. And I thought that that's kind of why we're here, as an advisory board, to really look at it in a more holistic kind of way. So just in terms of just listening and just some of the feedback, that was some of the things that I, just really concerned me.
Thanks, Robin. Just to say, agree that primary care does need to be part of addressing disparities. And I think that is, I definitely think part of that stated goal is to try to help make sure the system that is developed does attempt to do that. And we measure whether those changes are happening. Some of the data that we did provide was broken down by race, ethnicity from this past summer. And there are issues and there are gaps between the data we do have now again, I think there's opportunities to improve that data. And so we are working to do that, especially on race and ethnicity. And I think the other piece that you may have brought up is like collecting more holistic data as well. And there's definitely an interest in thinking about what does that mean. We've discussed, and I think maybe in this forum, a little bit about trying to capture data directly from members on their care experience and also experience of things like discrimination or bias in their care. And I do think there's a lot of opportunity for us to think about how could we capture that data moving forward as part of a system. We have tried to capture some member experience data previously. We do that both through the system as a whole, through our CAPS data collection, as well as in PCMH Plus under PCPCM. We're trying to capture data, and we've been trying to think about how to do this in our maternity bundle, where we capture more data that explains the care experience and how people are being treated by their providers. I think there is definitely issues of bias and care that could definitely be more person-centered, and we have opportunities to help drive that through how we design our systems. And I think that's part of this conversation.
Yes, and I also think the other thing that I wanted to also bring up, I heard something about even the improvements with Medicare, even in the emergency room. And I know even as a, pastor and also, as a faith-based organization, we hear this over and over again, how many of our people, parishioners and people in the community do use the emergency room for their, for things that they probably could go to for their primary care doctor. And even if they have one that they may have identified with, there's some issues around really, going to their primary care doctor and really feeling like the emergency room, is an immediate thing of being able to reach their needs. So I don't want it to also look like we're just really improving. Some things I understand the data, but sometimes, data also has stories. You have to get the stories also.
May I just add, this is CJ here. I'll just add a story to go with what the good Rev just said. It's so funny how the state of Connecticut has selective access to data, because when the COVID-19 vaccine came out, we saw who got it first. You cannot talk about payment and all of this without the proper data. You'll have the data to criminalize us. Where's the data to help us out? Thank you.
I'll just make a quick plug that one of the things that we had worked on CHN with CHNCT and Carillon and our other administrative service organization, Benicare, is to actually try and, when the COVID vaccine came out, we actually used data to prioritize individuals that historically were marginalized and had higher risk for acquiring it, to do outreach to improve COVID vaccines. So we actually spent a lot of time stratifying individuals and then trying to identify those highest risk communities and trying to do direct outreach to increase vaccine uptake. Again, acknowledging the data is imperfect and there's a work to be done, but we definitely are trying to use the data to hopefully target groups that historically the healthcare system hasn't always done a great job of making feel cared for and sometimes have taken advantage of. So acknowledging there's more work to be done. But I think just to say we are trying to incorporate that in our existing efforts, especially even related to COVID vaccine outreach. Robin, your hand's still up. I don't know if there's anything else you wanted to add.
No, I'll lower it. Thank you.
I think just if there's nothing else, we'll maybe move along just to keep, there's some more conversation we're really looking to have with all of you. Oh, sorry, Angela.
Yes, just with respect to programming design, is there any kind of priority, number one, just to close the conversation about the data, is there any priority the state is giving to close that data gap? Priority and funding to make that happen? Is that in anybody's budget or on anybody's task list of priorities?
It is, and there has been there is an ongoing effort and ongoing meetings to improve it. I'm not personally leading that, but Susan Smith on the DSS side is one of the key point people who you may or may not know, but and also at the OPM, Office of Policy Management. level, there's been a large effort to try to improve this throughout the entire state. I can't give you an update, Guy. I don't know if you have any more update, but I think it is definitely on our radar and something that is really, really important. So just acknowledging that.
Can
Yeah,
you put that on our agenda for an upcoming meeting to have someone come in and discuss that with us, what their projections are, and how we might be able to help, if at all? And the second question is in terms of access to primary care. One of the huge problems across the state is that we have a reduced number of primary care physicians. What is the state doing to attract and give incentives to new doctors to come and be here in Connecticut as primary care physicians, as opposed to higher paying specialties? That is got to be part of any kind of design moving forward, because we just don't have enough physicians.
Angela, on the first point, it's a good suggestion. I think what I might suggest in addition to what you said, Brad, I think we can work with Susan to put together just a primer, like a one-page memo on like the state of the world and like what % of our members do we have the data, what are the different sources. So Angela, why don't we take that offline? We'll write up something. I think it's a good question, and it obviously relates to a lot of the discussion we're having today. So we'll put something in writing, and then we can also have a discussion at our next meeting on that.
I would like to add to what's in writing, to add to what was just said. What are we doing to attract the medical students, the Black and brown medical students? I just left somewhere where I was served by someone who is Black, right? And not working in the field they should be. So I feel like this discussion needs to go further. So thank you for pointing that out, sir. We appreciate it.
Yes, CJ, I was going to get to Angela's second comment. She had 2 points. I was going to get to the second one. On the point of primary care supply, I think that is a really important issue. I think we need to think about the tools that this group has available to us as Medicaid, which are substantial but not unlimited. So, some of the tools we have available to us in this discussion versus federal partners or commercial payers, whatever. Some of the tools we have available include how and how much we pay providers and different specialists, which, just to go back to slide, that non-controversial slide, I was hoping on the payment model that's sort of part of what I mean by the payment model. And I guess the other potential tool we have is on our graduate medical education, and in particular, as the hospital settlement expires, there is a role the Medicaid program plays in graduate medical education. So I think those are the two most. I think it's a really big and important issue. I think those are the two primary tools that this audience has available to us. Others chime in with others. I'm just thinking about this on the fly. And there are other tools that this discussion doesn't have, but I certainly would invite input from others. The other thing I just want to recognize, I do agree on I think there's good evidence, good experimental evidence on the value of having Black primary care providers for serving Black patients, and thinking about the role that Medicaid could play on that particular issue is something I'd like to think about further. Others may have additional thoughts. One potential thing I've seen in other places is this isn't getting to CJ's question on the supply, but it's getting to the matching problem. I know some health programs, when a member calls in and is looking for a recommendation of a primary care provider, will ask a series of questions that might help the member find a PCP with whom they're most comfortable. And sometimes those questions could include questions of language or race. But anyway, I want to think more about that, but I invite others as well.
And I think Ellen, your hand's up, and Angela, your hand was up, I think, from before. I just want to make sure we've got Angela, any other comments you had before we go to Ellen? Nope. All right, Ellen, go.
I am so glad to hear you say that, Kate, because I would like us to look much more broadly than payment models. And I think there are a lot of things, as you said, there's good evidence around that can encourage more primary care, and not just physicians. Primary care is a team sport. Nurse practitioners, PAs have a very large role, and an appropriate role. Also, engaging community health workers and a lot of other people in the team. So thinking about a workforce that supports people and that's centered on the patient is really important. And there are things that are working in other states. The feds are allowing important increased incentives and other benefits for, say, rural care, for underserved areas. There are programs dedicated to this that work. And I would love to talk about what Medicaid and the state more generally could do to encourage that.
So Polly, and then I think I'm going to move us on after this one just to keep us moving. So Polly, go for it.
Yeah, thanks, Brad. I think part of what the care delivery reforms, what we can put on the table are those things that also really are supportive and are attractive to primary care providers that really help them, particularly with populations that have a whole host of challenging needs. Like we hear from our providers, they want more access to behavioral health resources. They know we need better, more robust community support. So they're looking for a lot of these enablers. And I think the more that, we can consider how, to provide the supports to the practitioners based on the data that we have, that also makes it, and ensure that some of the reporting requirements are less burdensome, right? We want to reduce the burden on the practices. We want to put supports in place that will really make it and enable them to meet the needs of the patients that they're serving and to get to the goals that we're looking to achieve in terms of achieving those health outcomes.
Thanks, Polly. So let's keep moving to the next section, and Olivia, when you get a chance, we'll pop to the next slide. So thanks for this very helpful conversation. I think this next section, I'm going to pass it over to Olivia to kind of quickly walk through kind of some very big picture what's happening in these very large bucket terms. So Olivia, pass it to you.
Yeah, thanks, Brad. So the next topic we have here is an attempt to sort of take a step back and take a more sort of global look at some of the things that Medicaid programs are doing in terms of delivery system and payment reform across the country. So I'll say all of this information comes directly from the Kaiser Family Foundation. KFS tracks the adoption of different models across the country amongst Medicaid programs. And so we are going to focus today on some of the most common models that Medicaid programs have adopted. We'll start with PCMHs. We'll talk a little bit about ACA health homes, accountable care organizations, and then episodes of care. Both of the conclusions at the bottom of this page also come directly from KFF. So they, acknowledge, and it's worth saying at the outset here, that there's, variation in how models, have been adopted, how states combine and implement the different models, how long states have been running these models. And then we've talked a little bit about the statement relative to literature as well. So I'll move forward and say, from the perspective of just giving you all a little bit of common grounding and some of the sort of broad models that are out there. I think many of you will be familiar with the PCMH model. DSS, of course, currently has a PCMH model in place. So you'll see Connecticut is one of the states shown here on the right-hand side in terms of states that have adopted PCMH. And just broadly, what is PCMH? It is a physician-led multidisciplinary care team that is tasked with holistically managing a patient's ongoing care, including preventative services, care for chronic conditions, and access to social services and supports. Providers that operate as PCMHs seek recognition typically from organizations, most notably the National Committee for Quality Assurance, or NCQA. That is true here in Connecticut. The current program also recognizes PCMH recognition from the Joint Commission, which is another recognizing body that certifies practices of having met the sort of capability requirements of a PCMH. And it's worth saying that the model, sort of as it's been implemented across the country, most typically includes a PMPM, a per member per month fee that's paid in addition to regular fee-for-service payments for Medicaid patients. Just to say, given that CSS has a PCMH model, this is quite similar in Connecticut. There is a PMPM, it's paid on a performance basis, so it does include recognition of performance on some quality measures. And in Connecticut, the fee-for-service payment structure remains, but PCMH recognized practices do get an enhanced fee-for-service payment rate. So they get a 24% increase on their primary care fee-for-service payments from the state. I'll move us along just to sort of give you the complete lay of the land, and then we'll stop from some discussion. But the sort of second example here we'll highlight is ACA Health Home. So this model was established by the Affordable Care Act. It's a little bit different from PCMH, most notably in terms of its more targeted focus on particular beneficiaries. So beneficiaries in a health home have to have either at least 2 chronic conditions, or have 1 chronic condition and be at risk for a second, or have a serious and persistent mental health condition. States have done some different things in terms of defining eligibility criteria for participation in a health home, but broadly, these models tend to be more targeted in terms of the populations that they focus on. Connecticut has a behavioral health home model, so a good example of a program with a more targeted population focus. Mark, I see your hand. Are you willing to wait to the end, or do you want to jump in now?
Well, I have a question about health homes, but I can wait to the end.
Okay, let me just let's suppose just to wrap on health homes for the benefit of the group. The worth noting, health homes provide a person-centered system of care. So providing access to coordination with primary, behavioral health, social and long-term services and supports. The range of services provided under these models can be typically more comprehensive than what might be provided under a PCMH model. And then from a funding perspective, just worth noting that states do receive an enhanced federal match rate for the first 8 quarters of a health home. Thanks, Mark. Go ahead.
So I'm just wondering, Olivia, what are the lessons with regard to health homes that have implications for primary care reform? It's tough at this level of description to understand in a more sort of functional basis what it tells us about, say, care team composition or clinical processes or whatnot that are necessary to achieve, to drive success with these patients with chronic illness. So I appreciate the significance of this innovative program, but I'm really trying to understand what it tells us about this next phase of planning.
Yeah, it's a great question and completely appreciate the point. Obviously, in taking a more global view, right, we lose some of the sort of granularity and specificity that we get when we look at particular programs in terms of what they're doing at the sort of care delivery level. So entirely fair. I think I will say the objective of this section is just to give the committee some broad grounding in sort of the kinds of models that exist. I think we're bringing health homes in and we'll have a little bit more discussion about this later on. In some ways, just as an example of a program that is much more targeted in terms of population. So health homes, as opposed to say PCMH programs, right, are typically looking at a sort of much narrower population and having much more sort of customized focus. So we do want to have a little bit of discussion with this committee about as we move forward with program design, are we looking for a broad-based sort of solution that it incorporates a wide array of members, as opposed to perhaps a more targeted? The other thing I will say, just to the first point, I suppose, is, as we move forward, I think we will want to bring in more specific examples from programs. To your point, I recognize it's hard at this sort of global level to grapple with what is this program, really about. But we'd like your feedback on that, which is to say, as we select programs that could help inform this committee thinking about some of the different options, we want to make sure we're incorporating your perspective on which programs. Obviously, we'll have to sort of select some, right, if we're going to look at programs in more depth. So wanted to just use this to set some context. We could have some discussion about that. I think as we move forward, it will be important to bring in examples at a higher level of specificity, if that makes sense.
Thank you.
I'm just going to kick it off by asking, what exactly do you mean by program design? Saying that because as a working Black person, I didn't have time to review these very detailed notes that were apparently shared and reviewed and discussed amongst others. I'll also like you to consider, while building a program design, what we just said about representation, right? As previously mentioned, a lot of Black and brown people go to the ER for primary care due to lack of access and also the lack of representation. Thank you.
Thanks, CJ. Appreciate those comments. I'm going to quickly go through the remaining two examples we've prepared and then open it up for some more discussion so we can get some feedback around particular programs and around populations. Two other examples, just to give you a sort of quick overview. Accountable care organizations, ACOs. Worth noting, this form has no uniform, commonly accepted federal definition, unlike the ACA health home. ACOs generally refer to a group of healthcare providers, in some cases regional entities, that contract either with providers or health plans or the state to share responsibility for the healthcare delivery and outcomes for a defined population. ACOs that meet quality performance standards that have been set by the payer and achieve quality standards, and savings relative to a benchmark can share in those savings. So with savings and good performance, ACOs are eligible to share in savings. It's worth noting programs sometimes use different terminology. So a lot of variation in this category. Colorado calls their ACO program regional accountable entities, and Rhode Island refer to accountable entities. So you'll see some different terminology used. In terms of adoption, a less widely adopted model, but a high concentration of ACO models amongst Medicaid programs in the Northeast. And then finally, episodes of care. Episodes of care are payments that provide a set dollar amount for the care a patient receives in connection with a defined condition or health event, so something like a heart attack or a knee replacement. This would be different than a fee-for-service payment where providers are paid separately for each service. And these payments usually involve payment for multiple services and providers. They create a financial incentive for physicians, hospitals, and other providers to work together to improve patient care and manage costs. And they are the sort of least adopted model, I would say, across Medicaid programs if you look on the right-hand side of the page. We've talked a little bit about this already, so I will just say quickly, as we're thinking about what these models mean and how we can think about DSS's starting point sort of within this framework, it is worth noting that DSS, as I said, has a PCMH program that's been running since 2012. And I think, as many of you well know, also a PCMH Plus program that's been running from 2017. That program really builds off of the PCMH model. It's a more advanced payment model and has more intensive care coordination requirements associated with it. And worth noting, FQHCs do get care coordination add-on payments, PMPM payment through that program. And then there is also the ACA Health Home model operated by TMAS that has a behavioral health focus in terms of population. So with that, and for the sort of prior discussion, we'd really like to hear from you all moving forward. You know, these are some broad categories of programs. I think, as Mark pointed out, you know, at this level, it can be, you know, hard to fully interpret what a program is doing. And so as we move forward and get more into program design conversations, we would like to bring in some more specific program examples to help frame options and to help give this committee, you know, the ability to consider some different, you know, ways that these types of programs are constructed. So want to give you all an opportunity to tell us, are there specific state or federal programs that you're aware of that you'd like to consider as part of this discussion, models or components that you think might be a good fit as we sort of move forward with, you know, in program design. We want to make sure we're acknowledging the kinds of programs that you all would like to look at in more detail. Ellen, I think I saw your hand first, and I will switch to editing so I can capture some notes.
Thank you. I think it's important. I'm sorry, I'm going to go off script. I'm not just going to give you federal and state programs. And this is just a short list of options that we should be looking at beyond, you know, the payment models, whatever Kaiser has on their page. I think it's really important to look beyond those things and to see which things there is evidence behind to improve. And unfortunately, you missed, I wish you had given a description about the intensive care management program in Connecticut. That is been very successful, and it's also targeted populations. And I would love to explore more about how we could expand that model and it connects extremely well to primary care. It's another thing I brag about in our Connecticut Medicaid program. I think of it as patient-centered medical homes at another level for people who need more than a patient-centered medical home. And it's really an incredibly powerful thing that we're doing. And I would love to explore how to support that and build it to where it's addressing some of the needs that have been brought up. Other issues are things like technology and the role of technology and what that could bring, suites of virtual and asynchronous services that are available, sometimes in concierge service practices that could be available and actually take burden off of primary care providers and expand access. I have brought this up before, but around payment rates and data for people with developmental disabilities, we know they aren't getting care. And well, in other states, we know that across the country. And actually, there was a new, you said, put out a survey just yesterday, I guess, or no, Tuesday, on in Connecticut, the trouble with accessing care for people with developmental disabilities. And that community, you should talk to them. I am not a disability advocate, but they have ideas of how to address that. Building on successful ICM, I said that switch patients, primary care case, PCMHs to primary PMPMs for the entirety of the care management piece, adding 25% to fee-for-service rates just encourages them to bring people in more, not only when not necessary, which is never good for people, but also to just for the care management. I'm reading what you're reading. I don't want to put 100% of the fee-for-service rate in, just to be very clear, to also free up slots for people who actually need a primary care slot. Better population health data. For instance, we have no data apparently on the people with developmental disabilities, which appears to be a massive blind spot. So I do think that it's a great conversation to have about targeting. And I know that's on the next slide, but I think we should do that. It's got a lot less chance of causing unintended consequences if you do that and then you measure really well. And we need CJ's and Angela's and everybody's points. We need much better benchmark understanding in places where there is a problem before we know whether we're making it better or worse. And I get very concerned. If there is a way to shift some of what, resources that might become available to this program away from screen and refer programs, which really don't work, and, just taking even the state's share to actually build those community services, which there is not enough capacity there, so that you're not referring to a wait list. And I worry a great deal in terms of program design. I think we should be very careful to make sure that when we're expanding resources to try to support something, that it doesn't just go into the black hole of huge health systems. And I'm not sure if I should tell the story, but there's a health system in Connecticut that, for instance, was giving out Thanksgiving turkeys. And it was tied to, reportedly, when I spoke to public housing residents, a concern to not testify against something that the health system was trying to push at the time. So, and also money just goes into health systems and we don't know if it's going to end up that somebody gets the care coordination that they need, that somebody with developmental disability gets longer than 15-minute appointments if we don't hold them accountable. So we need really good quality measures, which I will say on ACOs, the quality measures standards tend to be EZAs. 99.9% of the accountable care organizations nationally, this is in Medicare, always reach their quality measures. We need to make sure that they're meaningful and that they're a stretch, that we're moving things forward. We're not just saying, yeah, you did a good job, keep it up, just do exactly what you did last year. And that's just a short list. That's a tiny piece of the list, ongoing list of options that the advocates are already compiling in response to this request. But we need a lot more time to, and that's just, you shouldn't take that to be, I could get a lot of disagreement from people in the advocacy community about the things I just said. So you should take those just as my ideas, and I'll be coming back to you with a lot more.
Thanks, Sam. Let me go to David Kroll.
Yeah, thanks. I just wanted to mention the ACE Kids Act, the Advancing Care for Exceptional Kids Act, and the health homes and the definitions of a health home and the qualifications for kids specifically to be considered in this. For instance, the definition of health homes that we were presented is more of an adult definition with 2 or more chronic conditions within the ACE Act. It's one chronic condition that's affecting multiple organ systems. So there's different definitions, and I think it's just simple to keep that act in mind that allows for enhanced matching, federal matching rates for the state. So something else to consider.
Thanks, Angela.
Yes, for the sake of time and because I've spoken more than once, I've placed my question in the chat regarding health homes, medical homes. What that actually, what are those expectations, particularly as it relates to service and reporting? What are those standards, standard measurements that are requested? And what percentage of users actually truly are, have a medical home? So we can get some baselines. If before we start changing a system, can we actually show what the current status is? Thank you.
And Angela, are you talking about like our patient-centered medical home program, the PCMH potentially, and PCMH Plus?
Yes, and what, are there any state expectations with that designation? I don't know if that's a federal or state designation. Are there
Great
any
question.
expectations of those folks? You know, if that's a designation, what does that mean specifically as it relates to contributing to this process?
Thanks, Josh. Yeah, we definitely have information on this, and just for sake of time, we can bring that back another time. CJ?
Yes, so I'm a Black immigrant woman with asthma, so that makes me disabled and also part of a very other underrepresented group, immigrants, right? Now, as previously mentioned, you're asking us for feedback on stuff that you didn't give us time to prepare for. But I love what Angela and Ellen just said. Where's the baseline? So how are we supposed to set out and know these things? We're not being represented as is. You're sitting here and you're asking for program design. I asked a question, what do you mean by that? That wasn't even answered. So you're giving us very vague things and asking for feedback from the alleged community. I don't see us being represented. I never got the answer to the question, how do you plan to, if ever, appeal to medical students and, increase the number of Black and Brown primary care physicians? So I appreciate your time. I appreciate whatever this was, but I look forward to your actual answers. Thank you.
And I'll just try to quickly say, CJ, that at least in the program design, it is truly like, what's the primary care pieces? So what's the care? What are the care delivery components? What's the performance measure? What's the payment model? And the kind of subcomponents.
But do you see, Brad, what I mean? Like, okay, I knew what it was, but I'm asking the question on a bigger scale. If you want the community to give you feedback and tell you what they need, you won't get the real answer. But is that what you're looking for? Because when you don't give someone full information to answer to, you're only going to hear the answer to the question the way you want to hear it. I really appreciate your definition, but we could do better. Thank you.
And if you have an example of kind of what you're thinking for your definition, would definitely love to have it and would love to connect. I'll send you a message separately, CJ.
No, I'm not looking for an example of my definition. I'm trying to draw a point. We're having this meeting and I don't see the immigrant population being represented. We're very poorly represented, Black and Brown people. A lot of big questions were asked and very careful answers were given. We're supposed to give you feedback based on what you're bringing forward right here, right now. Most of us, Black and Brown people, are working people, right? We actually work, but we're also stigmatized. Most of us are stigmatized for living off the system. I don't see where what's happening now, mediates any of that. And I hope that we could do better. I hope next meeting we get our notes sooner, but we're also included in the conversation to create these notes so we could actually provide effective feedback. And I'm looking forward to your answers to Angela's data requests because our data matters too.
Well, just to say, I think primary care payment reform, unfortunately, isn't something that can fix all of the various issues. I think many of that you raised, and some of this is just things that either we don't necessarily even have control over. So primary care provider recruitment, I think there's things that we do have levers on, and Guy mentioned some of them in terms of thinking about recruiting a diverse workforce, but there's going to be challenges outside of what DSS has control over certain things. But we definitely have information, I think, around some of the questions Angela's asked, and I'll reach out separately just to make sure I understand some of the points you made. Paul, can I turn it to you?
Thanks, Brad. I pulled up, it's the primary care, the supplemental report that you all provided to us. It's a robust report that has an assessment that was done in 2022 that looks at all the work that had been done around primary care, what's working, what's not working, focus groups, kind of there are statistics in there about kind of what's working and what's not working. And at the end of it, there are a set of kind of observations and recommendations. And I'm wondering if that isn't where we should be starting. Mark goes back to studying primary care for 10 years, and this feels like another kind of fruitless exercise of hearing people talk about things that don't work, and and not talk about things that do work. So kind of from my perspective, and kind of if you reflect on all the information that's been provided to us, kind of a lot of work has been done that's Connecticut specific. Why can't we come up with some very practical things that we could implement soon? And I'll maybe close by just saying that fundamentally there aren't more primary care physicians because of pay. And we need, in my opinion, we need a multi-stakeholder effort to get more money to primary care physicians and more sophisticated models. Thanks.
Thanks, Paul. Maybe just take 1 second just to say, I appreciate you highlighting it. And maybe it's just good to remind folks that we did try to do a fair amount of stakeholdering including with focus groups last year to pull out some of the concerns, including with advocacy groups and others. And obviously you can always do more, but I think we tried to do a pretty extensive over the summer. And there's a lot of, I think, opportunities, as you noted, that were identified. And that's really what we're hoping to, I think, focus on. And maybe it's worth revisiting some of those again ahead of our next conversation. Maybe turn it over to Mark.
Yeah, I was thinking the same thing, Brad, that if anybody who wasn't here from the very beginning may have missed the extensive listening sessions that you did to inform this process so that this could be a more problem-focused endeavor. As I look ahead at the schedule, you have primary care capabilities, which I think is a focus on October 26th, then payment, and then you will have quality in there. What I'm wondering in terms of process is whether it makes sense to look at particular models or whether there's value to compiling the broad range, a description of the broad range of capabilities that have been employed in various models. And as Paul notes out, what's the evidence in support of certain functional solutions, so we can be really concrete and practical about what it is that we all think should be the starting point for adoption or promotion in this advanced care primary care model. So and so that's just a question as to whether it's for consideration, as whether you could do that kind of an analysis, so we're already looking at lists and can prioritize based on what aligns with the objectives of the program. In terms of points of reference, I think Paul knows that I have worked on primary care reform for a while. I think it is worth looking at the capabilities that were featured in the primary care modernization planning that OHS undertook and did not implement, but it has, for example, specialized capabilities for individuals with disabilities is one thing that was solved for in there, and the roles of care team members like navigators and coaches and that sort of thing. So I think that that initiative plus the Making Care Primary initiative, I think what's notable about that is CMMI looked back over extensive primary care model testing, and these are the capabilities they're focusing on today. And so I wonder if breaking down, they have a couple of page compendium of what the capabilities are that are a point of emphasis. And I think having something really concrete like that in hand may be a means to support the discussion. Total side note then on the payment model, I think it's important that I think there have been these, I want to just make the statement affirmatively that I do think that primary care capitation or bundling should be examined. And I'd encourage you to look at the full range of bundling or primary care for all, bundling or capitation for all primary care services, or just a portion of those services, or just the add-on things. I think that, whether we do that or not, and at this point, I think the hospitals are agnostic as to the value of that. We're going to be looking at that. I think it warrants a close look as to whether there's programmatic value, whether it will enable the kinds of outcomes that you're trying to achieve. And so I just wanted to make sure that somebody on the committee endorsed a careful look at that, whether or not it becomes part of the model. Thank you.
Thank you, Mark. We're getting close to the end. We appreciate the very thoughtful things that folks brought today. We did have one further kind of question, and I'll just say that it kind of leads a little bit to kind of as we're thinking about the program and where we're headed, but the population that we're focused on, and kind of keeping in mind some of the reform goals, as well as the focus that you all brought on addressing health-related social needs. That the initial approach, I think, is up for question. I think based on what we've heard so far, including on the programmatic design and the desire to try to address health-related social needs, or at least in some capacity, that the population that we'd start with would be a fairly broad one. But we welcome input on that. And I know that's come up already, that there's some concern with that. But it seems that, to achieve some of these goals, as well as some of the desires that come up with this group, that the focus would probably be broad, but wanted to open that up for a brief conversation. If we can keep any comments relatively brief, given the time, of course, we appreciate it. Go for it, Mark. I think.
Yeah, I just have a clarifying question, Brad, and I don't want to take up too much airtime. When you say broad versus targeting, are you talking about a program in which everybody in Medicaid would participate? That is, there might be PMPM, primary care add-ons for every Medicaid patient, but the targeting might be around the conditions that they present with. Or when you talk about a targeted approach, are you suggesting that, like the Health Home program, only certain Medicaid beneficiaries would qualify for inclusion in the model, and the advanced care payment and that sort of thing would be tied to them? The quality measurement would not be Medicaid population-wide or attributed population, or it would be, specifically for individuals with 2 or more chronic conditions. So I'm trying to get a sense as to what you mean by broader targeting.
More about the population that would fall underneath the umbrella of this programmatic redesign. So kind of, you said Health Homes, that's a fairly narrow targeted group, versus maybe what we would say under PCMH existing program is a very broad program that includes pretty much the entire population that falls underneath it. So that's more the broad versus narrow discussion.
So then a very short opinion is that I would propose a broad-based program like PCMH, but one that prioritizes certain healthcare outcomes, such as the chronic conditions I commented on before. But broadly inclusive would be my recommendation.
Ellen, please.
I don't want to leave anyone out, but I think if we don't put some boundaries around, not boundaries, a focus, shining a light on the things that people are talking about in, I've talked about in this call, and there are still areas of quality, obviously, that we need to address. If we don't focus on them and we just scattershot, the resources won't be as well targeted. And I also think it's going to be a whole lot harder to measure whether we're successful or not. So I think I'm not necessarily disagreeing with Mark. I think, chronic conditions make a lot of sense to talk about. Not everybody needs everything that somebody with diabetes needs, or someone with behavioral health conditions needs. So I think finding the people that the program isn't working for optimally right now, figuring out what they need and getting it to them. I mean, that's the crux of care management. That may be the same thing given the definition that you're giving as what Mark said. But I just don't think offering everybody, not everybody needs oncology. You only need it if you've got cancer.
Yeah, and I think there's opportunities within that broader framework to think about narrower populations within, but in terms of an initial starting place as we're thinking. So I think that's helpful. Any final thoughts? I know we're approaching the 12:30 and we're going to stop right around then, but Polly, go ahead, and David.
Yeah, I mean, I think there's kind of a both and, like we want to cast a wide net, but also kind of build the tools. And also I would hope we would have ways for this program to share learnings and successes and build upon interventions that are working, so we can, really kind of double down on the investments that are showing promise. So I think some flexibility in terms of how we want to choose the outcome measures and kind of reward and incentivize for that and allow some flexibility. But I think also being able to lift up, examples of things that are showing promise so that we can scale those to more members that might meet certain criteria.
Thanks. I know we're at 12:30 sharp. David, you had your hand up. Do you want to add one last comment, and then we'll wrap?
No, I think Polly hit on what I was essentially what I was going to say. I think I agree with what Polly said, and I think we just don't want to exclude the opportunity to focus on populations, and in my case, the pediatric population, especially those with complex chronic diseases.
Appreciate comments. We look forward. This will help inform what we bring to the in-person meeting. We'll wrap now. I know a lot of folks have to run to the next meeting, so thank you all. Appreciate the time. We look forward to seeing some of you in person and some of you virtually.